Okay, good morning, everybody. My name is Clarecia Rose Murray, and I am a Masters of Medical Physics student at UWA. Today, I'll be presenting the research that I completed as part of my Masters thesis and dissertation entitled Intrafraction Motion during CyberKnife Prostate SBRT, that's stereotactic body radiotherapy, impact of imaging frequency and patient factors. So this is a brief overview of what I will be covering today in my presentation. Introduction and background. The prostate is a small walnut-sized gland found only in men. Prostate cancer happens when abnormal cells in the prostate grow uncontrollably and form a malignant tumour. Prostate cancer is the most commonly diagnosed cancer in males worldwide, and second only to skin cancer is the most common cancer diagnosed in Australian men, with 1 in 10 men being diagnosed with prostate cancer before the age of 75. Thanks to modern treatment methods, however, the 5-year survival rate for prostate cancer is 9 in 10 males, meaning that 9 in 10 out of those diagnosed will survive for 5 years or more. Common treatment methods include hormone therapy, surgery, and radiation therapy. Radiation therapy is what I will be covering today. The 2 main types of radiation therapy typically delivered for prostate cancer are conventional radiotherapy methods. These have several fractions, usually delivered daily, spread out over several weeks, somewhere between 36 and 39 fractions, although this can vary. SBRT, and specifically we're going to be discussing SBRT with CyberKnife today, is typically delivered over 5 fractions for prostate cancer. These treatment times are obviously longer because there is only 5 delivery fractions and the dose is higher per fraction. This study is going to focus on CyberKnife SBRT. So during the treatment planning for prostate cancer for treatment with CyberKnife, the visible tumour is imaged and a margin will be taken that encompasses the visible tumour and any microscopic disease around the tumour. 3 to 4 fiducial, gold seed fiducials usually, are implanted into the tumour volume, and this is used to track the tumour during the delivery of radiotherapy. Margins will also be applied to the clinical target volume, and these are called CTV to PTV, being planning target volume. And these are to encompass things such as setup errors, organ motion during treatment, and any prostate deformation that occurs during treatment. Any kind of radiotherapy delivery requires geometric verification. With precision for high dose radiotherapy, such as that delivered with CyberKnife, precision is especially important. So at Sir Charles Gairdner Hospital, where the research was undertaken, we have near real-time tracking that is acquired via images, KV imaging, that's X-ray imaging with orthogonally placed cameras. This is capable of providing vectors in the X, Y, Z, that is the superior, inferior, left to right, and anterior, posterior directions, and rotations about each of these axes. The robotic CyberKnife arm that you can see in the picture then can actually move and adjust the beam position to correct for any organ motion that occurs during delivery. The radiation therapists typically set imaging to be about 15 to 20 seconds initially when a patient's undergoing radiotherapy, and this will be progressively increased to 45 seconds depending on patient stability. Frequent imaging is associated with accurate treatment delivery. However, it also increases the cost and the treatment duration, and also we need to consider the X-ray total body radiation dose. So the optimization of the imaging frequency and patient margins is quite important and somewhat novel research. So before we talk about what was covered in this study, we'll just briefly go over the literature. There is three main studies that I'm going to mention. The first was tracking that was done in real time, and this is Curtis et al. Was concluded rather that 15, 60, and 240-second imaging combined with 1, 2, or 3 millimeter planning margins were adequate to capture 95% of the motion, to cover basically geometric accuracy for 95% of the time. And this was used with conventional radiotherapy, fairly short treatment deliveries, and Calypso tracking system, which is different to what we use, using electromagnetic transponders. The second is Shi et al. This study actually was completed using CyberKnife tracking data, and they concluded that 2 to 3 millimeter thresholds with 30 and 60 centimeter imaging frequencies was adequate to capture 95% of the data set. And this was very similar setup to what we have at Sir Charles Gairdner Hospital, with mean of 5 fractions and the KV tracking. The third one I'll mention is there has been various studies that have tried to individualize patient margins based on various clinical factors, including BMI and delineated volumes such as bladder, rectum, and prostate. This one in particular looked at BMI and margins and found that higher BMI was correlated with less prostate motion in the superior inferior dimension. And this was acquired via imaging pre and post fraction delivery. So the aim of this study was to characterise intrafraction prostate motion as a function of imaging frequency using the treatment data gathered from patients treated with CyberKnife at Sir Charles Gairdner Hospital, to develop a model to optimise imaging intervals and applied geometric margin combinations, to investigate clinical factors that may or may not predispose patients to intrafraction motion, and assess the potential impact on geometric accuracy if beam reposition had not been employed. And in this study, that's been called prostate drift. So the methods used to do this: there were 331 patients treated between 2014 and 2021 in the cancer clinic at Charlie's. These patients, their tracking data for each fraction, which involved 1,792 files, is stored on using the precision treatment planning software on site. This data, the flat files, were manually extracted during times when the relevant PC was not in use. And if you can have a look at the second screenshot down, you can see all of the X, Y, Z, roll pitch, and your vectors that were acquired. This was iterated over with Python and concatenated into one big structured table for analysis. 52 treatment plans were also extracted. These included the delineated volumes of the bladder, rectum, and prostate, and the patient clinical factors such as age, weight, and height were queried from Mosaic and the CyberKnife registry. So all of the analysis was completed, and all of the transformation and loading was completed with Python, and any missing values that needed to be derived and various data quality checks were done here, such as checking that patients hadn't been extracted twice and so forth. As the data is displayed in vectors that are relevant to the planned position, and this study was primarily focused on the motion that occurred during each image and therefore during each beam correction, that we needed to derive some variables, so such as those displacement from imaging. So we use each image as an offset. Also needed to look at the deviation from the initial delivery from the first image verified delivery position. Velocity between each consecutive imaging was image was taken, and I will cover why this was acquired in future slides, and also using the Euclidean distance to calculate speed and standardized motion for all imaging intervals for looking at clinical factors. So typically, the imaging intervals are 15, 20 to 45 seconds. However, this restricts us to only being able to study these if we're only to look at the raw data. So the velocity that you saw in the previous slide was calculated in order to estimate the positions that occurred between each consecutive imaging interval. And this allowed the resampling of the data in order to simulate several different imaging intervals. The extreme positions in each direction were taken and vectors acquired, and the imaging interval was simply binned as in or out of the given threshold. The analysis of, as mentioned prior, the Euclidean distance was taken over the change in time, and this was gathered so that we could look at age, weight and height influences on the motion, regardless of what imaging interval that they were imaged at. Due to time restrictions and the manual extraction processes, rather than looking at the entire cohort with the delineated volumes, the patients were ranked by their CTV speed, and a subset was taken from the upper and lower quartiles, and a paired analysis was performed on these, simply a two-tailed Mann-Whitney U-test. So the results of this study. This is the raw imaging data here on the left, independent of any kind of patient grouping. As you can see, by far the most common intervals are 15, 20 and 45 seconds. And we can see the spread of motion that is on the right-hand side in each plane. However, as mentioned previously, this only allows us to study these imaging intervals. And as this is not aggregated on patient, this does not tell us a whole lot about individual patients and how their motion might be spread. So this is where the simulations were useful. So we were able to look at the percent of time that a patient would likely spend within a given threshold based on the resampling of the data after taking the velocity and estimating vectors in between recorded positions. This was repeated for 1, 2, 3, 4 and 5 millimeter thresholds for all of the imaging intervals that you can see there on the x-axis. As you can see, there is quite a wide spread of data. This is giving us the percent of time that for patients spending, of their treatment time rather, spending within the given threshold, and the line on the box plot is obviously just the mean of the patient cohort. This was repeated in the superior, inferior, left to right, and anterior, posterior directions, as well as the roll, the pitch, and the yaw. The results of the prostate drift, this is looking at the mean, this was done by grouping all patients' motion and taking the mean of means and standard deviation of means per minute of treatment, and grouping them to get some characteristics on how the prostate moves relative to the first image verified position. And as we can see, the prostate standard deviations, which is the dashed lines on the image there, increased as treatment delivery went on. And this is for the rotations, roll, pitch, and yaw. The analysis of patient factors, looking at age, weight, and height first. The data, due to a direct linear relationship between speed and patient features, there was a low R-squared value, which was not surprising. However, as this data is usually considered within thresholds, a cutoff was applied at a speed of 1 millimeter per 45 seconds to produce a new binary target variable. And this allowed classification models to be tested on this data. So this was done for many combinations of age, weight, height, and BMI, and for several different models, with the humble logistic regression in the end being what was published. We can see here that age, height, and BMI gave the best mean area under the receiver operator curve of 64%. However, BMI performed not very far behind, with the mean area under the curve of the RAC curve being only 2% less. Unfortunately, due to limited height availability, any models that included height or BMI could only be based on 44 patients. The results of the paired analysis showed no significant let me restart that. The null hypothesis was not rejected at an alpha equal to 0.505 rather. So we detected no significant differences in bladder, rectum, or prostate volumes between the two subsets from the upper and lower quartiles ranked on speed. However, if we look at the second to the rectal volumes and the prostate volumes, and given their still relatively low p-values, there may be further research here warranted. So looking at what all this means and comparing it with some prior literature. It's quite common to look at in the literature results, values which result in 95% geometric coverage. Furthermore, it's quite common for 5mm margins with 3mm in the direction of the rectum to be applied to during prostate treatment. And although these margins are there to encompass more than just intrafraction motion, these are still interesting thresholds to look at. So when we look at these, we see 3mm and 15-second imaging is adequate for the mean patient to achieve greater than 95% time within threshold. And the same can be said for 5mm and 45 seconds. And we also have 3 degrees and 15 seconds and 4 degrees and 45-second combinations to achieve approximately 95% of time within threshold. Comparing it with the 3 studies that were mentioned in the outset, this study reports greater intrafraction motion than what was reported by Curtis et al. However, Curtis et al. Does disclose that they report a best case scenario due from frequent repositioning. And our study does have significantly longer times. Our study had 35-minute mean treatment time compared with their study, which was 7 minutes mean treatment time. She et al., we did have some similar results for 30-second imaging. However, our simulated images for 3mm rather and 4mm thresholds did indicate that shorter intervals were needed. However, it is important to note that our data was relative to a 10mm CyberKnife tracking threshold, which means that the treatment will actually be interrupted and CyberKnife will not track further than 10mm. However, she et al.'s study was relevant to a 5mm tracking threshold. And in regards to comparison for the patient features with Thompson et al., we were not able to see any significance for BMI with either negative or positive correlations with motion. However, given that we had different methods for measuring motion and the limited size of the patient cohort, this is not a full comparison, and there may be some more research required there. There was some functions put together for the mean geometric accuracy, and OLS was done on the simulated percent of treatment thresholds using stats models in Python. And this is just for the mean geometric accuracy as a function of threshold in each translational plane and chosen imaging interval. However, as there was such a large spread of data from the mean, this function was not published as it only describes the idealistic patient. So to conclude, there were very many combinations of CTV and to PTV margins and imaging intervals that may result in adequate geometric coverage, but further research into the dosimetric implications of viable combinations of motion thresholds and imaging frequency is recommended, particularly looking at total body dose for extra imaging, or rectal toxicities that apply when shifting margins around need to be considered. So this may open the way for future research here. Finally, this data was published recently. A subset of this data was published recently in Physical and Engineering Sciences and Medicine. So that was very exciting on the 27th of March. And these are the references that I have mentioned today in my slides. Ethics approval. And thank you very much to all these people. Thank you to my supervisors, my co-authors. Thank you very much to Pejman. Specific thank you to these people that helped with the analysis. Radonk at Charlie's, the Department of Health graduate program in which I was employed for part of this research, the UWA Medical Physics Research Group in general, and of course, I will always mention the machine learning cluster, who were very useful during the course of this research, and lots of things were bounced around during this time. And thank you very much. It was a very special time, and I look very fondly at this time in research. So I've included this picture of us all. Thanks for listening.
Okay, great. Thanks, Clarecia. Very nice presentation. Any questions? Yes, everyone busy with encouragement. Okay, Martin, you want to have a question?
Yeah, I guess it's just really fantastic work, Clarecia. It was a great effort, and I guess if you could have had sort of any access to any variables you wanted to try and pin down exactly those patients that are going to be, you know, in that 5% who are outside these sorts of thresholds, what do you think you might have needed to find, you know, to work out who those patients are?
That's a good question. I think that given the interesting results for the rectum and our prostate volumes, I think that'd be where I would start, as especially for prostate volume, the alpha, the p-value was 0.064. So this is actually very close to the cutoff of 0.05. And obviously rectum being 0.19. I think that it would be interesting to look at these for a larger percentage of patients, for sure, given that such a large data set there as well, that's including of the motion.
Mm-hmm. Do you think there may have been some maybe problems with some patients in terms of you know, following bladder filling guidelines and those sorts of things?
There definitely could have been, but this was difficult to quantify as there were no records available for me to see who had and had not followed those guidelines strictly. It would only be reporting anecdotally from the radiation therapists. I guess if there was a way to quantify that and to know that for sure, that would be very interesting.
Okay. Any other questions from Clarecia?
I had a question.
Sure, Ashley, sure.
Hi, Clarecia. That was really good presentation. So you used like Mann-Whitney test for in the study. Do you think, and you mentioned that it was done to like sort of save time and that was feasible. So what could have been like the more efficient alternative to it? Is there some other model that could have been used instead of it?
Yes, 100%. If we had had the time to acquire the delineated volumes for the entire cohort, various machine learning methods could have been used, whether that be regressive and there be some linear models attempted to be fitted to that data, or whether it have been similar to the other patient features where a cutoff was used to create a classification model. Both of those could have been investigated if we had been able to get the entire cohort. Yeah.
Okay, thank you.
Okay, great. So, Clarecia, is there any cost and benefit if we change the 10 millimeter tracking threshold for CyberKnife? I mean, if we, for example, reduce the threshold to 5 millimeters, would it be possible? And what would be the cost if you want to reduce it?
So if we reduce it, it will just result in more frequent treatment interruptions, because when they go outside of tracking, if it's just transitory, so they'll often take another image, and if it's transitory and they move back in, they will not go and shift the patients. However, if they remain outside of whatever the tracking threshold is, they'll go and physically move the bed and a new file will be created. So this does result in longer treatment times. So I think it's definitely something that other clinics have done and what I've seen in the research. However, if CyberKnife is capable of tracking that far, it's still adjusting once it detects it's not like it's going over there and then staying there and delivering dose. It'll then adjust and bring its arm back over. So I'm not sure that there's a lot to be gained by reducing that threshold, really, because it's always picked up. Yeah.
Good, thanks. Any other questions? Okay, no other questions. Brilliant. Thanks, Clarecia. Well done.
No worries
Excellent.
at all. I'll stop
Excellent.
sharing.
Excellent. And Martin, could you please